Good evening, friends. Today I am going to discuss a very important topic, uh, sepsis in ICU and its antimicrobial management. Sepsis is defined on the basis of systematic systemic inflammatory response syndrome criteria. Systemic inflammatory response syndrome has following components: temperature either below 36 degrees Celsius or more than 38 degrees Celsius, heart rate more than 90 beats per minute, respiratory rate more than 20 per minute, and total leukocyte count 4000, either less than 4000 cells per cubic mm or more than 12,000 cells per cubic mm. So these are the criteria for systemic inflammatory response syndrome, and sepsis is SIRS, systemic inflammatory response, for in view of infection. So more than two or more than two criteria are required to identify systemic inflammatory response syndrome. So sepsis is SIRS with more than two components. Next thing is severe sepsis. Severe sepsis is sepsis along with end organ hypoperfusion. End organ hypoperfusion. So sepsis along with end organ hypoperfusion, like a decreased urine output, altered sensorium. So these are some features of end organ hypoperfusion. And third is septic shock. Septic shock. Septic shock is features of severe sepsis plus persistent hypoperfusion. Persistent hypoperfusion. Persistent hypotension. Systolic BP less than 90 mmHg, or unable to maintain mean arterial BP less than 65 mmHg. So unable to maintain more than 65 mmHg, along with the features of severe sepsis, despite of optimum fluid therapy and vasopressors. So it's a septic shock, and which ultimately culminates into the multi-organ dysfunction syndrome and mortality. In 2016, there are certain modifications to definition of sepsis. The terms like SIRS, sepsis, septic, severe sepsis, So they have removed some terms like systemic inflammatory response syndrome from the definition, and severe sepsis. They have kept two things. One is sepsis and septic shock. Sepsis and septic shock. Severe sepsis. They have kept sepsis and severe sepsis. They have removed septic shock. Sepsis and severe sepsis. This definition is known as sepsis 3. Sepsis 3 definition. Sepsis is life-threatening organ dysfunction caused by dysregulated host response to infection. So, life-threatening organ dysfunction. Life-threatening organ dysfunction and dysregulated inflammatory response. So, dysregulated inflammatory response. So, two components are there: life-threatening organ dysfunction and dysregulated immune response, inflammatory response. In the previous definition, the focus was merely on the inflammatory activation because of sepsis. But now it is known that sepsis is not only pro-inflammatory, it also anti-inflammatory. So both type of pathophysiology present into the septicemia. That's why it's a dysregulated inflammatory response. Septic shock is subset of sepsis. Where underlying circulatory and cellular metabolism abnormalities are profound enough to substantially increase mortality. Where the circulatory and cellular metabolic pathophysiological changes are profound enough to substantially increase the mortality. So the problem, it is a component of sepsis where the circulatory function as well as the cellular metabolic functions both are hampered, and which lead to ultimately end organ damage and hypoperfusion and cellular death, leading to mortality. So in this definition of sepsis, organ dysfunction is frequently mentioned. So there are certain scores or parameters to measure organ dysfunction. Scores to measure organ dysfunction. So first is sequential organ failure assessment. SOFA. It has maximum score of 24 and minimum of 0. And any change in SOFA score, 2 or more than 2 score changes from the previous value, is considered as indicative of sepsis or increase in the infection, and mortality risk also increases up to 10%. The components of in the SOFA, we measure all the vital organs. We take into consideration of values indicating the function of all vital organs like cardiovascular system, respiratory system, liver function, renal function, and CNS, CVS, respiratory system, liver, renal, coagulation profile. So 6 components are there, and scores are from +0, +1, +2, +3, +4. Here the Glasgow Coma Scale, in the CNS function Glasgow Coma Scale is used, where the score is this Glasgow Coma Scale score 15 and almost normal, and the 13 to 14, 12 to 13, and 10 to 12, 6 to 9, 6 to 9, and less than 6. Again I will write here, there's some mistake. It's a 15 in the +0, and 13 to 14 in +1, and 10 to 12 in +2, and 6 to 9 in +3, and less than 6. This is the Glasgow Coma Scale. In cardiovascular system, we measure the BP, mean arterial BP. It is more than or equal to 70. Less than or equal to 70 is a hypotension. And next, if the hypotension requires vasopressor dopamine support, and dopamine less than 5 microgram per kg per minute, less than 5 microgram per kg per minute. And if it is not sufficient and dopamine is more required, more than 15 microgram per kg per minute, or it needs further NORAD support 0.1 microgram per kg per minute, or adrenaline support. Similarly, further inotropic support in the next criteria, next grading. Now the respiratory system measures the PaO2 FiO2 ratio. Normally it is more than 400. Now it's less than 300, less than 200, less than 100, and platelet and coagulation profile. So more than 150, less than 150, less than 100, less than 50, and less than 20 platelet, and renal function and liver function. So in the renal function, less than 1.2 creatinine 1.2 milligram per dl, 1.2 to 1.9, 2 to 6, 6 to 12, and more than 12. Sorry, this is a liver function, it is bilirubin. And renal function similarly, creatinine 1.2, less than 1.2, and 1.2 to 1.9, 2 to 6, 2 to 3.5, 3.5 to 5, and more than 5. So less than 1.2, 1.2 to 1.9, 2 to 3.5, 3.5 to 5, and more than 5. So it's a bit cumbersome, but it helps in predicting the mortality, since it takes into consideration of multiple parameters and slight complicated for the emergency use or rapid assessment. So we need a rapid assessment method, so which can be done on the bedside. So we have devised second score, that is Q-SOFA. This is quick sequential organ function assessment, sequential organ function assessment, which takes into consideration three parameters: tachypnea, respiratory rate more than 22, respiratory rate more than 22, Glasgow Coma Scale, mental alteration, Glasgow Coma Scale less than 14, and also systolic BP less than or equal to 100 mmHg. So Q-SOFA 2 or more than 2 indicates the risk of infection. 1 point given here, 1 point. If score is more than or equal to 2, it indicates the infection. There are multiple scores available and all causing multiple confusions. Just I am mentioning the name, like Apache 2 score. This is the acute physiology and chronic health evaluation. Acute physiology and chronic health evaluation score in the ICU. It's a computer generated score where multiple parameters are taken into consideration. Its score is from 0 to 71. And another one is news. Another one is news and muse. So national early warning score and modified early warning score. These are the scores: national early warning score, modified early warning score. Lactate cutoff is, before proceeding further, we should know about sepsis bundle. Sepsis bundle and sepsis bundle is devised a plan to properly manage the septicemia in ICU as a guideline, which there are various pathways and guidelines available, but sepsis bundle gives us an accurate idea with which we can get the optimum result and maximum survival rate of the patients. So sepsis bundle is from the survival sepsis campaign. SSC. What are the components of sepsis bundle? First and foremost, we have to do a lactate check. Which is, if the previous lactate value is more than 2 millimoles per liter, then we have to again recheck lactate, and after checking lactate, we have to take a blood culture sample before starting broad spectrum antibiotic. Third is broad spectrum antibiotic immediately starting. The sepsis bundle is considered within 1 hour. So it is also known as sepsis bundle 1 hour. Earlier it is known as sepsis bundle 3 hours and 6 hours. Now it has been merged in the new guidelines and it is known as sepsis bundle 1 hour. We have to start the treatment immediately as soon as possible. We have to start antibiotic as soon as possible. We have to load the patient with crystalloid, plenty of fluid, and start antibiotic broad spectrum as soon as possible. So first we have to do lactates, then blood culture, and then broad spectrum antibiotic. And fluids, crystalloids, a lot of crystalloids, more than 30 ml per kg body weight. For a 70 kg man, within 1 hour we can load with 3 to 4 liter of fluid. And fifth is apply vasopressors. If the BP is still not getting maintained, if mean arterial pressure is not going beyond 65 and patient is showing a symptom of end organ hypoperfusion, then we have to start the fifth component, that is vasopressors. The pathophysiology behind the sepsis. Pathophysiology behind sepsis is that sepsis or septic shock, it will lead to cardiovascular circulatory failure. How the circulatory failure happens is because myocardial suppression, hypovolemia, vascular tone irregularity, and decreased systolic BP, decreased cardiac output. So these are the reasons for circulatory failure, and unable to maintain. And along with that, there is increased tissue metabolism, increased oxygen requirement, and tissue hypoxia. These are the processes, these are the pathways with which the body is unable to maintain the end organ perfusion. And leading to ultimately mortality or multi-organ dysfunction. When to start the antibiotic? There are two things. One is sepsis is definite or probable. Sepsis is definite or probable, and sepsis suspected or possible. So sepsis is definitely present or probably present, then we have to immediately give antibiotic immediately without delay. Antibiotics immediately without delay, whether patient is in shock or no shock. We have to give antibiotic immediately in both of the areas. If there is sepsis, definitely we have to start antibiotic immediately as soon as possible within 1 hour. And if there is a sepsis possibility is there, then we can start here also antibiotic immediately if the shock is present. But if there is no shock, we have time, we can think about the infectious or non-infectious region of sepsis, infectious or non-infectious region, differential diagnosis. And if we find that there is possibility of infection, we can start immediately antibiotic within 3 hours. So this is the timing of starting antibiotic. Biomarker of sepsis to titrate the antibiotic support is procalcitonin, serum procalcitonin. Normal value is less than 0.1 nanogram per ml, and if it is more than 0.25 nanogram per ml, then it indicates infection. So it is a biomarker of infection. So after utilizing sepsis bundle, we are going to start the broad spectrum. Within the sepsis bundle, we have to immediately start the broad spectrum antibiotic. If there are unknown source of infection, then immediately start vancomycin 15 milligram per kg body weight BD twice daily, 15 milligram per kg, along with piperacillin tazobactam combination. 3.375 gram 8 hourly, or in place of piperacillin tazobactam we can also use meropenem, and that is 500 mg 8 hourly. This is till the blood culture report arrives. And antifungal agent also need to be started. Antifungal is injection microfungin 100 milligram IV OD. Microfungin 100 milligram OD IV. There are other regimens when we suspect the abdominal infection, when we suspect the urinary tract infection as a primary cause. So finding the cause is very important to start the particular antibiotic. Like in abdominal infection, abdominal source of infection, we can start with the piperacillin plus tazobactam combination or meropenem. Piperacillin tazobactam or meropenem, or metronidazole along with cefepime 1 gram 6 hourly. In case of UTI, we have to start ciprofloxacin plus gentamicin plus ceftriaxone. In skin infection, we can start with vancomycin or linezolid. So there are various regimes for various type of source of infection. Now, what type of vasopressors we are going to start? The vasopressors, there are three kinds of vasopressors. Pure vasopressors are phenylephrine, isoprenaline or isoproterenol, vasopressin, levosimendan, and pure inotropes. Are those drugs which act on alpha and beta adrenergic receptors. We all know, like noradrenaline, dopamine, dobutamine. These are the drugs that act on alpha and beta receptors. And pure inotropic, these are the mix, because they have dopamine, adrenaline, noradrenaline. These three have mixed action of both vasopressor and inotrope. Dobutamine on the other hand, has pure inotropic action. Along with milrinone. To clarify this confusion, I have made some mistake here. Now I want to clarify that pure inotropic agent are dobutamine, isoprenaline, milrinone. Vasopressor, pure vasopressor are phenylephrine, vasopressin, and angiotensin 2, and mix noradrenaline, dopamine, and epinephrine. Let's talk about individual agents. Noradrenaline. Noradrenaline is mainly acts on alpha 1, then preferred beta 1, and then preferred beta 2. So it causes peripheral vasoconstriction. And its T half is 1 minute, dose is 0.101 to 2 microgram per kg per minute. Adrenaline, it acts on alpha 1 as well as beta 1 and followed by beta 2. It acts on all the adrenergic receptors and dose is 0.01 to 0.1 microgram per kg per minute. Dopamine acts on dopamine receptors and then beta 1, then beta 2, and dopamine has a 3 kind of action at a very low dose, medium dose, and high dose. At a low dose and medium dose, 0.5 to 2 microgram per kg per minute, 2 to 10 microgram per kg per minute, 10 to 20 microgram per kg per minute. Beta 1 and alpha 1 action predominant. So at low doses it acts on the dopamine receptors. At mid dose it acts on beta 1 receptors, and high dose acts on alpha 1 receptors. Preferably. Dobutamine acts on beta 1 receptors, causes tachycardia, dose is 2 to 20 microgram per kg per minute. Vasopressin acts on V1 V2 receptors. V1 is vasculature, smooth muscle cell of the vasculature, and this is the V2 is on renal collecting duct. It causes water retention and dose is 0.1 to 0.1 units per minute. units per minute, usually 0.4 units per minute is given. There are other agents like milrinone, that is phosphodiesterase 3 inhibitor. Milrinone is phosphodiesterase 3 inhibitor, and it acts on the cardiac musculature, and loading dose is 50 microgram per kg. It's loading dose. Infusion is 0.375 to 0.75 microgram per kg per minute. And levosimendan is a cardiac troponin C binding, which increases the stroke volume in the heart, as well as it opens the potassium channel, which causes vasodilation. So it has both kind of action. On the one hand, it increases the cardiac output. On the other hand, it causes vasodilation. So increases the systolic blood pressure but reduces the diastolic blood pressure, and used in the decompensated heart failure. Sepsis is a very vast topic. Further discussion we will do in the next video. Thank you.